Okay, perfect. So I'm going to speak first about heart failure in women, and then I will come to sex-specific cardiomyopathies. So this is the outline of my presentation. There is a lot of data that estrogen modulates a variety of pathophysiological processes, including the endothelial response to injury, the renin-angiotensin-aldosterone system, and the left ventricular remodeling. Estrogen has roles in maintaining diastolic function and also in the coronary vasculature. These may explain the sex differences in heart failure pathophysiology at a mechanistic level. There is one very good paper from the European Heart Journal looking at the association of long-term outcomes and biological sex in patients with acute heart failure from different geographic regions. Data from national registries suggest that acute heart failure outcomes may vary in men and women. However, it's not known if this observation is universal. In this particular study aimed to evaluate the association of biological sex and 1-year all-cause mortality in patients with acute failure around the world. They included various heart failure registries, and the one was great registries, which had mainly data from Asia and Europe, and the optimized heart failure registries, which has 26,000 patients from the US. In the great registries, women had a lower risk of death in the following years in acute heart failure, and this was mostly driven by Northeast Asia, the hazard ratio of 0.76 and a p-value of 0.001. There's no significant differences seen in the other countries. In the optimized, as the American registries, women also had a lower risk of 1-year death. Women were less often prescribed with a combination of ACE inhibitors and beta blockers as discharge, was significant, but globally women with acute heart failure had a lower 1-year mortality despite being of less evidence-based therapy than in men. There is also a study which I thought is relevant for the topic. It's a study which was published in Lancet 2022. It's a strong HF study. The safety and tolerability and efficacy of up-titration of guideline-directed medical therapy for acute heart failure, a multinational open-label randomized trial, where also we took part in this trial. And you can see that the rapid up-titration in hospital had a profound difference on 180 days readmission for heart failure and all-cause death. It was also analyzed if that's different, and according to different subgroups. And you can see here an analysis according to ejection fraction, baseline systolic blood pressure, baseline NT-proBNP, region, and gender. But it found that according to all the pre-specified subgroups, there was no difference, and it was beneficial in irrespective of the different comorbidities, ages, if you started with a lower or higher ejection fraction, and there was also no difference in the sex-specific analysis of the strong heart failure data studies. I think most of us will know that women have more commonly heart failure with a preserved ejection fraction. In a study who actually found or documented that for the first time was a study in the European Heart Journal in 2013, which showed this is really a difference how women present with heart failure. So if you look at, there's a beautiful recently published paper in Cardiovascular Research from 2022, and they summarize the sex differences in the epidemiology and treatment of heart failure with reduced ejection fraction. You can see that women had a lower lifetime risk heart failure with reduced ejection fraction compared to men. They're more likely to have non-ischemic etiology of heart failure with reduced ejection fraction. When you looked at medication, you can see there's a survival benefit of ARBs relative to ACE inhibitors. With an unclear benefit of ACE inhibitors. We actually like the trials, they were underpowered. If you look at device therapy, women are less likely to have an ICD inserted. It's unclear survival benefit of ICD in women. there's a greater benefit of a CRT in hospitalization, mortality, and quality of life outcomes. If you look at advanced heart failure management, women are less likely to have mechanical circulatory support for cardiogenic shock. There's increased combination on durable MCS, so mechanical circulatory support, most likely due to the incorrect sizing. There's increased mortality with heart transplantation. If you now go to specific cardiomyopathies, so now cardiac amyloidosis is 80 to 90% of the cases are in men. At presentation, women have a higher LV systolic function and lower wall thickness. Hypertrophic cardiomyopathy, women are typically older and more symptomatic as first evaluation. Women are more likely to have obstructive physiology. Greater mortality also in women. Cardiac sarcoidosis is more common in women. They have lower endomyocardial biopsy utilization for the diagnosis in women. Women have lower rates of ventricular arrhythmias and less likely in ICD implantation, and higher in-hospital mortality in women. Stress or cardiomyopathy is much more common in women. Emotional stress predominant trigger in women, and physical stress predominant the trigger in men. Male sex is predictor of adverse event, including cardiovascular death, heart failure, and ventricular arrhythmias. Coming now to cardiomyopathy, which is specific in women, which is peripartum cardiomyopathy. So there are many causes of heart failure, many forms of structural heart disease, which I've just mentioned, the various forms of cardiomyopathy. And if you have a patient who has a pre-existing cardiomyopathy or has documented heart failure, planning a pregnancy, or presenting during pregnancy, there's a detailed position paper from the European Society of Cardiology and the Heart Failure Association, going into much details of all the different cardiomyopathies or post-cancer therapy or post-transplant. And it's really a good reference work if you need up or give advice specifically to a patient with a rare form of cardiomyopathy. It also should be managed as a multidisciplinary team. Coming now to peripartum cardiomyopathy, it's an idiopathic form of a cardiomyopathy, present with heart failure towards the end of pregnancy on the months following delivery. No other causes of heart failure are found. The diagnosis is of exclusion. And LV ejection fraction is usually below 45%. The etiology and the pathophysiology, our knowledge of pathophysiology of PPCM has changed over the past 50 years. We initially thought in the 70s it's due to viral myocarditis, then hypothesis of nutritional deficiency, hemodynamic stress of pregnancy was a main thinking about the condition in the 1990s. In the 2000s, we started to look at various forms of inflammatory cytokines, picked up the prolactin variation, androgenic imbalance, and now in the 2020s, there is a paper from us and others on proteomics, cholesterol metabolism, inflammatory pathways, and more data on genetics. You can see that in Japan, the incidence is only 1 in 20,000, and in Nigeria is 1 in 1,000, 1 in 100. South Africa, we have 1 in 1,000. Germany is 1 in 1,500. But what is quite striking that it's more common in the sort of tropical belt compared to the northern region, including, for instance, Denmark, 1 in 10,000. We know now that it's most likely that you have two hit systems. So you probably have a predisposition, like a genetic predisposition or other predisposing factors. And then the second hit triggers around the time of pregnancy, which is led by an androgenic imbalance caused by an abnormal or 16 kilodalton prolactin fragment, which leads to vasoconstriction, inflammation, apoptosis, endothelial dysfunction, and programmed cell death, and that can be blocked by the medication bromocriptine. We know now that it's really recommendable to include genetic testing in the workup of a patient. And if the mutation is identified, that also leads to family screening. We learned a lot from the global registries financed by the European Society of Cardiology, and there's a number of publications. I think more than 10 publications came out from this registry, which is still ongoing. So we do know from the global registry, which has more than 750 patients from 49 countries, that at 6 months you had thromboembolism in 7%, mortality was 6%, readmission was 10%, my recovery was less than 50% in 6 months, and neonatal mortality 5%. Just recently, the 1-year data have been published, and you can see that approximately 1 in 12 patients had died by 1 year. Thromboembolism stroke occurred in 6.3%, but most likely in the months post-diagnosis was a marked regional variation in 1-year mortality with a frequency of all-cause deaths in the Middle East approximately 4 times that of Europe, 3 times that of Africa, approximately twice from Asia Pacific. And the reason for the regional variation are most likely multifactorial, and there are possibly difference in genetics, comorbid conditions, but also the healthcare facilities. Around 1 in 7 women have been rehospitalized in 1 year, and LV recovered is still less than 40%. So PPCM remains associated with a substantial mortality and morbidity globally. So this is my last slide now. So as a number of unmet research domains at PPCM, we need more research into epidemiology. There are many parts of the world where we don't know much about the condition, better understanding of the genetic involvement. Proteomics and metabolomics is really, I don't have time in this 50-minute lecture to go into the new data, but they really will help us to understand the pathogenetic better, but also the management better. We don't know if it's safe to stop the medication in women with heart failure who have recovered their heart function. We still can have to work on improvement in drug therapy. We will very soon have the data on the safety of subsequent pregnancy that will be published soon. And we need more data on neonatal outcome. So with this, as my conclusion, globally women more commonly have heart failure with preserved ejection fraction. In general, a heart failure in women often has a better outcome. More sex-specific trials are needed adjusted for body mass index. The peripartum period is a vulnerable time for all women with underlying cardiac disease. And risk stratification and management of pregnancy in the postpartum period for women with the diagnosis of structural heart disease and a history of heart failure is complex and requires the input of a multidisciplinary team. Thank you very much.